can you just say explicitly what is the worry where you're like a threshold of 1,000, a threshold of 500, a threshold 200, where people need to act faster
So
explicitly?
when
What's happening?
neutrophils are 500 or less and what we can measure in the blood, we worry that the total body neutrophil counts are low, which means that a person is not going to be able to robustly fight off any sort of infection or disease and might need things like IV antibiotics or closer monitoring more than someone who has an ANC that's 2,000 or higher. As hematologists, we are not worried about infection risk when someone's ANC is 500 or higher. There is usually minimal to no impact on infection risk when someone has an ANC of 500 or higher. And so I know we have learned and parsed out neutropenia as mild as 1,000 to 1,500. I am not worried about that category at all. Maybe it's a yellow,
Even with a
even
fever.
with a fever, I'm
Yeah.
not worried about that, at least from the febrile neutropenia risk. 500 to 1,000, I hesitate, and I really look at that patient, and I assess, has it been stable? Are there other things going on? What's their context? But it's not a cut and dry, every person every time has to go to the hospital with a fever if their ANC is 800. That might be normal for a lot of your patients, whether that's autoimmune neutropenia or it's the Duffy null-associated neutrophil count. You really got to look at that person in front of you. I think the closest to binary or a clear-cut thing I can say is that when an ANC is less than 500 and there is any signs of fever or infection, that is a send to the hospital almost every single time for extra supports and monitoring and almost always IV antibiotics.
Um, Thank you for clarifying that. And then neutrophils, we need it for all viruses, bacteria, all the good stuff,
Oh
right?
yeah,
It's not
yeah. Neutrophils are a workhorse. The cell that's the most common, and it really fights off like all the infections. And again, bacteria is like the main one, but fungal is common. If you want to emphasize though that our concern about fungal infection really isn't there until neutrophils are 200 or lower. And again, that's really in the context of multiple days. So not like a snapshot of a day or two, but multiple days. And we get that data from our leukemia population. Again, we extrapolate a lot of things we learned about neutropenia from leukemia or chemotherapy populations, and some of it applies, but I also think it's important to recognize that that's where the data is coming from. And so it may apply to your patient with autoimmune neutropenia or with the Duffy null phenotype, but maybe it won't. And so I think holding really tightly to that or being confident that what we know from leukemia or chemotherapy and its impact on neutrophils applies to causes of neutropenia is one of the biggest mistakes. And it's pausing and realizing, is this a patient, an oncology patient who's just had some sort of myeloablative therapy? Or is this like a walking, talking, healthy person that just stumbled into your primary care clinic and happens to have a neutrophil count of 900, right? Very, very different scenarios and a very different mode of evaluation.
This is, I don't know, maybe this is too theoretical, but do you have like a hierarchy sometimes of like, say, people who have like, relatively similar like neutrophil counts, but they have different causes? Like one of them, it's from leukemia, another person who's from like autoimmune. Are there certain causes of neutropenia that you think put people at like, say, like higher infection risk, even if they might have similar neutrophil levels?
Yes, that's a great question. So any process that impacts the bone marrow and specifically impacts you from hematopoietic stem cell all the way to mature neutrophil is going to put you the most at risk for infection, right? And so the big things there are aplastic anemia, leukemias, any sort of chemotherapy,